सरप्राइजेस क्या, बैठे बैठे कुछ है वो चलता रहना चाहिए। ठीक है, चल खिसक नहीं रहा, एक सेकंड। Screen sharing has stopped. The shared window is closed. Okay. उसका तो आप वीडियो चला दो, ऑडियो चला दो सर। नहीं नहीं नहीं, वो मैं एक बार देखूं तो सही ये हुआ क्या। ये सारी टेक्नोलॉजिकल चीजें हैं, ये ऐसे ही गड़बड़ हो जाती है। इनका भी अपना मूड होता है सर। हाँ
हाँ बिल्कुल।
हाँ, यहाँ से यस।
हाँ अब चला।
तो good evening and welcome Dr. Vikram Mahajan, our
Sir, good evening.
Very good evening, and we will I welcome Dr. Vikram Mahajan, Dr. Agarwal, Dr. Lalit Gupta, our team of Rajasthan, doing good activities every week, and we have done almost along with some few in pipeline 52 of these evening lectures and class which probably this thing. So we want to present you a virtual bouquet, so kindly accept.
Oh, so nice. I'm pleased. I'm honored. I'm honored, sir.
and Rajasthani Safa.
Safa, bilkul.
And I'll request Dr. Agarwal to kindly introduce Dr. Vikram Mahajan. Dr. You have
already introduced मेरे ख्याल में तो
doesn't matter. Dr. US.
Yes, sir. Good evening, sir.
Yes.
And good evening, Dr. Mahajan, our Dr. Dinesh, Mathur, sir, Dr. Lalit, and all members who are sitting today in this webinar. Dr. Vikram Mahajan is Professor, Dr. R.P. Government Medical College, Kangra, Himachal Pradesh. He is a teacher, academician, researcher, as faculty, and has published more than 2,000 publications in
Sir, 200.
200 publications in national, international, peer-reviewed journals, chapters, and monograms. He's got wide academic interest, including clinical dermatology, melasma, psoriasis, allergic contact dermatitis, sporotrichosis, leprosy, and cutaneous leishmaniasis. He has won many awards, recognitions, including nominations for Young Scientific Medal Tropical Medicine, Royal Society of Tropical Medicine and Hygiene, UK, Himachal Pradesh State Award for Excellence in Leprosy Control Program in 2001, 2002, Himachal Shri Award, IDVL Best Teacher Award in 2019, Best Published Paper in IDOS in 2019. He was awarded as the IDVL First Prize for Thesis Guide in 2019 and was awarded IDVL Second Prize for Thesis which was guided in 2020. So with this rich biodata, I'll request Dr. Mahajan to enlighten us on the subcutaneous mycosis today.
Just a minute.
Thank you, sir. Thank you very much. हाँ जी sir.
एक मिनट वो मेरा जो है just a moment. We have prepared a evening this thing. Well, good evening, and please start sharing your screen. Just a moment. Yes, please. Welcome, Dr. Vikram.
Okay, sir. We'll start. Is it visible, sir?
Very much visible. Excellent.
Okay, sir. Okay, sir. Thank you. Thank you very much. Thank you very much for Dr. Dinesh, Dinesh Mathur, Dr. Lalit, Dr. Agarwal for giving me this opportunity again. And just a few disclosures. Now I'll start with the topic main. This is subcutaneous mycosis. And subcutaneous mycosis, of course, every day. I mean, I won't say every day, but some significant number of times we see these patients in our OPDs, and of course they are difficult to treat cases, and sometimes they are even difficult to diagnose. So we'll start with the just a brief introduction to these deep mycosis. And deep mycosis almost contain, I mean, constitute about 1% of all mycological disorders. Of course, superficial dermatophytosis or yeast infections or candida infections, they are more common as compared to the deep mycosis. Systemic mycosis, again, it involves lungs, CNS, and bones, while the subcutaneous mycosis involves skin, subcutaneous tissue, fascia, and adjoining tissues. Infection usually follows traumatic implantation of the fungi. And because this is infection depends on the traumatic implantation of the fungus, so there is no age, gender, or race is spared. And males probably in most series reported are to be affected more often, and this is probably because of their higher exposure to the occupational injuries, and rather than any gender susceptibility. And of course, these infections are more common among people or among populations who are handling plant or plant material, like agriculturists, foresters, and nursery workers. And I mean, now there are two types of pathogens which can cause subcutaneous mycosis. One are the true pathogens like Histoplasma capsulatum or Sporothrix Schenkai. And others are opportunistic like Candida infection or Aspergillus or Cryptococcosis. Now, what is the importance of subcutaneous mycosis? Of course, it's very important to diagnose them early because it usually affects younger people who are more exposed to the occupational injuries, and they probably suffer more often. More often they acquire the infection, and the diagnosis is definitely important for early treatment and management. In the early stage, probably the disease is more amenable as compared to the late diagnosis. So treatment most of the time remains unsatisfactory, especially if the patient has a very long history of acquiring this infection. And most of the time, these infections have a very chronic, protracted clinical course and cause significant morbidity in significant number of patients. And of course, nowadays the incidence is rising because of immunosuppression, maybe because of immunosuppressive therapies, organ transplants, HIV infection, and some people even blame, or some people even implicate global warming as a cause of increased incidence of subcutaneous mycosis. Now, recently, there is a changing epidemiological spectrum, especially even in the immunocompetent individuals, you may find more disseminated kind of disease. And of course, drug resistance and new pathogens are being introduced every day or every year. Resistance, of course, is known in some of these fungi, and new pathogens, of course, we have seen some new pathogens which have not caused disease in the past, but now they have become more pathogenic and causing disease, especially among immunocompromised individuals. clinical spectrum, of course, commonly these are the infection. These are the subcutaneous mycosis varieties. Sporotrichosis, of course, the commonest, followed by chromoblastomycosis, phaeohyphomycosis, entomotheromycosis, and mycetomas, which can be actinomycotic or eumycotic. Actinomycotic are basically bacterial infection, but eumycotomas are basically because of true fungi. Rhinosporidiosis and lobomycosis. Rhinosporidiosis, of course, is more common along the coastal areas. Lobomycosis we do not see in India because this is has a very limited endemicity, especially localized and is localized to the in the New World, in the Venezuela, Brazil, or Latin American countries. Other infections, they are emerging infection like penicillium because of penicillium marginiferi. This is very important probably, and probably this is one of the marker of HIV infection nowadays. Scedosporium, again aspergillosis, and these are again emerging infections which are of course more common in immunocompromised individuals. Diagnosis, of course, is difficult sometimes because they all have almost similar morphology. So clinical suspicion remain the key for early diagnosis in these individuals. These infections, they have to be differentiated from cutaneous tuberculosis, cutaneous leishmaniasis, atypical mycobacteriosis, pyoderma gangrenos. Particularly ulcerating lesions of these subcutaneous infections, they need to be differentiated from other ulcerative causes, and a pyoderma gangrenos has been mistaken in number of case reports. Cutaneous neoplasias again is another area which can lesions which can mimic subcutaneous mycosis. Now coming to the infection proper, sporotrichosis, like I said, it is the most common infection among all subcutaneous mycosis, and it is reported bird bite, and particularly in the tropical or subtropical countries. The major the causative or yeast is basically Sporothic Schenckii. It is a basically complex of many cryptic subspecies, and the majority of the time it is caused by these 6 subspecies of Sporothic species, commonly known as Sporothic Schenckii complex. And among in India is a sporotrichosis, Sporothrix Schenckii globosa, which is the predominant organism to cause sporotrichosis in India. This can present endemic disease. It can present a sporadic case disease, or in a clustering in clusters, or it can present as epidemic, like in Brazilian countries. It is still going on as a epidemic. In India, endemic this disease is endemic in sub-Himalayan belt, and sporadic cases are reported from other states. Large series has been reported from Himachal and Assam through the years, but there is no epidemic thing has happened in India. Manipur probably is a new endemic area, and it has again reported a single large series of cases, and of course they are positive, culturally positive cases. And dead vegetation remain the major source of this yeast. There are 2 clinical forms. Majority of the time, it is cutaneous sporotrichosis, or it can present as extracutaneous systemic sporotrichosis. Cutaneous sporotrichosis in almost 80%, more than 80% cases will present with lymphocutaneous variety. Fixed cutaneous variety has less common, but it has some kind of the host resistance is there, so it is a limited kind of disease, and response is better in case of fixed cutaneous variety compared to lymphocutaneous variety. It can present as a disseminated cutaneous sporotrichosis or multifocal kind of infection. In extracutaneous or systemic sporotrichosis, osteoarticular infection is probably more common. Other is the most common form of systemic disease. It can present as a pulmonary disease, or through hematogenous spread, it can involve the CNS also. This is the typical case of lymphocutaneous variety of cutaneous sporotrichosis. Usually what happens, there is a implantation of the positive fungus in the skin after minor trauma or occupationally acquired trauma, and subsequently it forms a small sporotrichoid chancre, small non-healing type of ulcer, and subsequently the new lesions or nodular ulcerative kind of lesions, they appear along the lymphatics in a chain-like form, and the disease remain active in most of the patient unless it is specifically diagnosed and treated. So this is again case of lymphocutaneous variety. You can see the chain of there's a traumatic inoculation site because of trauma, and then subsequently the new lesions have appeared almost of similar morphology along the lymphatics. This is again a kind of lymphocutaneous variety. Again, the new lesions, they have appeared along the lymphatics, and probably some cutaneous nodular lesions again have manifested with nodular ulcerative kind of the skin lesions. Fixed cutaneous variety, again, this usually involves face and is more common in children. Usually there is a single lesion at the trauma site itself, and it can mimic various diseases. We'll see that various differential which can need to be differentiated in this. This is again multifocal kind of thing. This patient had a large sporotrichosis of the face, and subsequently there is auto inoculation of the fungus over the hand. So he had multifocal kind of thing. Multifocal means lesions are present on non-contiguous skin sites. This is a traumatic inoculation because of air prick, and subsequently the patient developed these lymphocutaneous variety of nodular ulcerative lesions of the sporotrichosis, lymphocutaneous sporotrichosis. Again, nose prick has led to this kind of infection in this patient. And mind you, this again, the small lesions can appear around the primary lesion, and this is because of the destabilization of the disease, not because of the lymphocutaneous variety, but because of destabilization of the disease. Because of local trauma, maybe of a biopsy, can destabilize the infection, and the new lesions can appear at the periphery of the main lesion. This is again trauma because of roadside injury, and subsequently the patient developed these kind of ulcerative lesions, and subsequently it was non-healing kind of ulcer, and pathologically and histologically sporothrix chancai could be grown in this their biopsy tissue from this. Again, a sporotrichosis of middle finger, and again because of trauma, there was inoculation of the infection, inoculation of the yeast, and subsequently the patient developed this non-healing kind of thing. And this is what we say is again because of trauma, there is an involvement of the underlying bone, so osteoarticular involvement is quite common in some of these individuals. Again same osteoarticular involvement, trauma site, and the new lesions appeared again along the lymphatics in this patient. So it's a combination of lymphocutaneous variety as well as underlying bone involvement. This is again a patient, interesting patient. She had multiple lesions in a linear pattern, and this is the actual picture. And for many years, she had been diagnosed as a case of lupus vulgaris, and received a course of ATT without any benefit. And she had presented with highly pruritic lesions. And we diagnosed initially as a case of nodular prurigo, but subsequently histopathology revealed granulomatous inflammation, and culture revealed sporothrix chancai. So this was treated, and this is a post-treatment scarring of this patient. Over the nose is again common site, plaque-like lesion which can mimic tuberculosis or lupus vulgaris. Over the periungual area, again warty hyperkeratotic lesion of fixed cutaneous sporotrichosis. Again, this is a pyoderma gangrenosum-like lesion, non-healing type of ulcer, and again typical sclerosed borders, and hyperpigment or discoloration at the periphery, and almost purulent discharge like that of pyoderma gangrenosum. This is again a case of sporotrichosis, which initially was diagnosed as a squamous cell carcinoma, but histology and culture showed sporotrichosis. Again, initially diagnosed as a lupus vulgaris, but subsequently when biopsy and confirmatory reports received, it was a case of fixed cutaneous sporotrichosis of the face. Histologically, usually histology is not very typical of sporotrichosis, but it can vary from acute or chronic kind of infection or granulomatous infection or true granuloma formation with giant cells, multiple giant cells. And some, if you are lucky, you may find this splendour Oakley phenomena or asteroid body in some of the sections. But of course, this is a very not a very easy to find out, and most of the time is difficult to identify or difficult to find also. Now, culture identification. Culture is important to identify the cause. It can be grown. The fungus can be grown from the skin biopsy or other clinical samples on the inoculator of Sabro's glucose agar and brain heart infusion agar. And it is inoculated at 25 degrees centigrade as well as at 37 degrees centigrade on SDA and on brain heart infusion at 25 degrees centigrade. The growth is usually in 3 to 5 days, but we leave it for 2 weeks, and before discarding we usually wait for 4 weeks for the fungus to grow. This is the typical colony of Sporothrix shankai. Initial colonies are cream colored, and they eventually become the initial colonies are cream colored, and then they mature to brown black color because of the melanin pigment in them. This is a smear from the culture. This is a hyphal form. Usually from the culture we see hyphal form, and very typical. This is a lactophenol cotton blue smear, and you can see the spores. They are in a flower-like arrangement. They are on the very delicate hyphae. They form a sleeve-like pattern. And if you inoculate this fungus again or in SDA at 37 degrees centigrade, you will find the yeast form. So it gets converted to yeast form, and you will find typical yeast-like structures, yeast-like cells, or cigar-shaped bodies. Cigar-shaped bodies or yeast-like, budding yeast-like structures in the gram stain. So if you demonstrate this dimorphism of hyphal to yeast form, this is very characteristic feature of Sporothrix shankai, which is known as temperature dimorphism. So clonic characteristics and demonstration of this temperature dimorphism is very characteristic of Sporothrix shankai, and almost confirms the diagnosis in the absence of more advanced tests like molecular studies like PCR and all those things. But most of the time we don't have PCR facilities in most of the institutes, and in those cases probably clonic characteristics and this demonstration of temperature dimorphism is important to confirm the diagnosis of Sporothrix shankai. Now the next is chromoblastomycosis and phaeohyphomycosis. Now there is a confusion, rather chromomycosis, chromoblastomycosis, and phaeohyphomycosis. Chromoblastomycosis, when we find sclerotic bodies, so sclerotic form of the fungus in the smears or in the histopathology sections, then we say it is a chromoblastomycosis. That means it is a infection of the subcutaneous. But in case of we find hyphal form of the organism in the histopathology section, then we say it is phaeohyphomycosis. And chromomycosis is umbrella term for both the conditions. So a chromomycosis can present as a chromoblastomycosis, or it can present as a phaeohyphomycosis. Common pathogens are, of course, the most common is Fonseca pedrosi, Fonseca compacta, and all these other organisms. But Fonseca is probably the most common cause of chromoblastomycosis or phaeohyphomycosis, both. Of course, new fungi are being identified: Cladophylophora, Pylophora richardsii, Exophylla, Genselmai, Spinifera, Epidermatitis, Dermatitis, Vaginella dermatitis. They are newer fungi which are being identified. And from in a recent years from India, Histidon species again has been identified in some of the cases. Clinically, classically it presents as a chronic varicose or nodular lesions, mostly over extremities or the trauma site, cystic lesions and few hyphomycosis, and again is more common among males and agricultural workers because of occupational trauma and handling of plants. Traumatic inoculation is the main cause of the disease, and of course, hot and humid climates are conducive for the growth of these fungi. This is a case of chromoblastomycosis of a very characteristic varicose lesion. If you notice them, there is a healing also concurrently, but most of the time you'll find they are non-healing kind of varicose lesions at the trauma-prone sites. Again, a patient on the elbow, and if you note, this is a very characteristic lesion of a chromoblastomycosis varicose scaly lesions, and if you notice there was small black dots. This is again small black dot. They indicate basically bleeding points and the microcolonies of the fungus. So again over the hand, this is a again varicose lesion over hand and a crusted scaly varicose lesion over the elbows. This is again a case of chromoblastomycosis over the forearm. Again typical lesion. Now in KH mounts, if you scrap these these lesions, if you scrap the scales from these lesions, particularly from these black dots, you'll find these kind of sclerotic bodies or copper penny bodies in KH mounts. These are very typical. They are basically biseptate, or they have a formation. They are separated by the septa at right angles. So you'll find these copper penny bodies in KH mounts, but demonstration of these copper penny bodies inside the giant cell is more important histologically. Otherwise, histology is just granulomatous disease with a lot of hyperplasia, pseudoepitheliomatous hyperplasia, and granulomatous inflammatory infiltrate. But demonstration of these sclerotic bodies will be diagnostic of chromoblastomycosis. Second is pheohyphomycosis. This patient we had involvement of face. Of course, there is a diffuse involvement. There is hardly any wrinkling on the face, and this patient had perinasal area involvement with the cystic kind of lesion. Of course, not very prominently seen in this case, but subsequently Forsythia pedrosa was grown in these cases. This is again pheohyphomycotic cystic lesion over the foot in a diabetic patient, and this demonstration of hyphal form was done in case of histology sections. Of course, you'll find all granulomatous inflammatory infiltrate, but demonstration of either sclerotic bodies or hyphal form. If you demonstrate hyphal form, then it is basically pheohyphomycosis. But in case if you demonstrate sclerotic body or copper penny bodies, then it is a case of chromoblastomycosis. This is a cystic lesion of pheohyphomycosis over sole, and this is after treatment. And otherwise, they are smooth surface, paleness, hardly any symptom in these cases. This is a culture characteristics of Forsythia pedrosa. Again, tissue was grown on SDA or sabrodextrose agar. Usually they start as cream colored colonies, subsequently they become olive green, and subsequently lastly they become more black in color. And this is very characteristic LCB mount, and this characteristic arrangement of the conidiophores or the spores is very characteristic of Forsythia pedrosa, and this is known as Forsythia synannomorph. And if you notice they are very broad kind of hyphae with septate. This is again a case of pheohyphomycosis in a diabetic patient, and here we isolated Rytid histidon rufulum, which was confirmed by PCR studies. And this is again after the treatment of this patient. Again, histology of this patient showed again acute on chronic inflammation. But if you notice this presence of various forms of the hyphae. This is characteristic of Rhytihistrion merofilum, you'll not find any spores in the LCV mounts. They are only separated. They do not sporulate in the culture media. Now, next is mycetoma. Of course, mycetomas, there are two types. One is of actinomycotic or second is eumycotic. Most common, of course, is actinomycotic as compared to eumycotic. Eumycotic, they are true fungi, but mycetoma, actinomycotic mycetomas are mostly caused by nocardia. And clinically, almost they look similar. This is a nocardial mycetoma of the gluteal area, again of the thigh and of the back. Back is uncommonly involved in some of the patient because of the some people in a habit of carrying swelled sacks or the some weight over the back, and that may lead to or the plants or the firewood, or sometimes the grass fails on the back and they may get traumatized, and subsequently there is inoculation of this mycobacterium, nocardia, and that leads to these kind of multiple discharging sinuses. If you notice them, they are very characteristic of nocardia. Scarring is usually by puckering, but if you note this, the nipple-like lesions and with a lot of purulent discharge coming out from these lesions. And crusting, of course, is a feature of the dried up this thing. Nocardial grains, you can demonstrate them in KH mounts. They have different shapes and number, of course. They are just nothing but nocardial colonies, microscopic colonies, and you can demonstrate them in the discharge of coming from these lesions, and they have different shapes. And of course, in gram stain, you can demonstrate these grains. Again, this is a sun ray appearance of nocardia, and this is in pass and this is in gram stain. Culture, of course, this is again basically nocardia has a it grows only on algae medium, like tuberculosis is a AFP positive, it is a Z Nelson positive, and it grows on algae medium. And if you notice them, they are again they are small, they are delicate filamentous structures which are Z stain positive, and colonies are very small and yellow color. Now, next is rhino-orofacial conidiobolomycosis. Again, this patient had rhino-orofacial conidiobolomycosis or conidiobolomycosis usually involve the orofacial lesion, rhino-orofacial skin. Because this infection is usually because of the paranasal sinuses. There is inhalation of the spores, and subsequently the infection settles on the paranasal sinuses and the adjoining tissue, and then it manifests as swelling of the lips or the paranasal areas. This is again patient of rhino-orofacial conidiobolomycosis. If you carry labial regions, and sometimes it involves the gums and the oral mucosa. Next is mucormycosis. Mucorma is usually seen in immunocompromised individuals and is very common in diabetics, especially when the patient has ketoacidosis, and again is a rhino-orofacial only, and it is an emergency basically. So it can cause very destructive lesions and it's very fast, spread very fast to the CNS, and it usually becomes fatal. Histoplasmosis, this is a patient of histoplasmosis, disseminated variety, and this disseminated variety is usually seen in case of immunocompromised individuals. This patient was HIV negative positive, and he had multiple lesions, small nodular lesions, which showed the presence of histoplasmosis. This is a pharyngeal involvement. In another patient, these histoplasmosis can present as a pharyngeal involvement alone, and subsequently these kind of patients, they are more prone to get adrenal infection with this. Disseminated variety can present chest involvement, lung involvement, and this is the primary histoplasmosis after the traumatic inoculation. And in smears, you can demonstrate histoplasma capsulatum is a round, large nucleated bodies with a clear capsule around in the surrounded by a clear capsule. Colonies are white, fluffy, and cottony, and in smears you can demonstrate large spores and very delicate hyphae. Treatment of subcutaneous mycosis, of course, we don't have many treatment options. And another thing is, another problem in treating these patients is there are no clinical trials, no randomized clinical trials. So most of these treatments are on the basis of case reports or small case series, and we don't have any guidelines when to stop these treatments. So roughly, we usually give these treatment for almost years together. Roughly, it is after the clinical cure, to achieve the mycological cure, you have to continue the same treatment at least for 2 to 3 months more. So potassium iodide, saturated solution of potassium iodide still remains the first line therapy, which can be used in almost all these subcutaneous mycoses alone as well as in combination with other drugs. It usually started as a 5 drops in a saturated solution of SSKI. It usually started as a 5 drops 3 times daily, and maximum dose is 30 to 40 drops TID daily, or till the patient develops metallic taste. Metallic taste is the threshold of the upper limit of the drug dosage. So you have to reduce the dose of SSKI in these patients once the patient develops metallic taste. Or if the patient can tolerate up to 30 drops, most of the time, most of the patient we have seen is they tolerate up to 30 drops, but sometimes they may develop some kind of flu-like symptoms. In those cases, probably SSK remains contraindicated. Parotid swelling is another problem with SSK, and some patients do not tolerate metallic taste. So in those cases, probably you do not give SSK. Itraconazole is again the second line. Basically, in our setup, is a second line drug, but in Western countries, itraconazole remains the first line therapy for all subcutaneous mycosis, and it can be given almost 400 to 600 milligram daily in divided doses. It can be combined with SSK, or it can be combined with other drugs. Tropinephrine is up to 1,000 milligram per day has been used for various subcutaneous mycosis. It has been used for sporotrichosis as well as for other mycosis infection. Amphotericin B again is a good drug, but it only disadvantage, it has to be given parentally, and it can be given. It has to be given IV actually, and the liposomal drugs formulation probably are less toxic, but they are costly. So most of the time they remain unaffordable. The mycetoma patient we have treated with intralesional amphotericin B, and it had showed good response. Antibiotics, nocardia is amenable to the antibiotics, and we have Welsh regime, which includes aminoglycoside, combination of aminoglycoside and cotrimazole. Amikacin is usually given for 3 weeks and combined with cotrimazole, and subsequently another 2 weeks are to be given for with the cotrimazole is given for another 2 weeks. So 5 weeks period combines one cycle of therapy, and most people require almost 3 to 4 cycles of this combination therapy. But again, it's difficult to stop drugs in most of these patients, and probably they have to treat it for years together. Heat therapy, cryotherapy. Heat therapy is for sporotrichosis is a choice for chromoblastomycosis, but alone they are not effective. So probably you have to combine them with specific therapy with it. Surgery, of course, is not a very good choice, but some small lesions can be excised totally, particularly for chromoblastomycosis, because it's very difficult to treat. They usually do not respond to common these anti-azoles or other drugs, and small lesion have to be treated surgically and combined with this systemic therapy with itraconazole. Again, cryo can be used as a destructive therapy for the small lesions, but again, large lesions probably will not respond to these alone. Again, for mycetoma, surgery probably has to be deferred. Amputation should not be a choice for any kind of mycetoma. because it's better to have a bad foot rather than no foot. And most of the time in a pain length condition, patient can manage with it, and patient can continue with the treatment or whatever the treatment you have decided. For actinomycotic, probably is easy to treat, but eumycotic cases probably require almost lifelong therapy because the fungi probably is difficult to eradicate from these mycetoma. Thank you very much. Sir.
Thank you, Dr. Mahajan, for your very exciting and excellent talk.
I hope, sir, I could do justice
Oh,
to it.
yes, it was an
Yes,
excellent, excellent.
You did a great justice to the topic. I think our postgraduates must have certainly been benefited by your talk.
I hope so, sir. I hope so.
Oh, very much. And it was a very rare rare cases and these things. So, Dr. Lalit,
Yes,
please
sir.
present this virtual bouquet to Dr.
Sir,
Mahajan.
any questions, sir? Any questions from
Oh,
anyone?
questions तो इसके बाद में लेंगे ना यार.
Okay, पहले बुके देना है. Okay.
हाँ.
Thank you very much, sir.
पहले बुके. Dr. Lalit.
Yes, sir. मिल गया, sir.
Yes, sir.
Thank you.
So, Dr. Mahajan, it was wonderful listening to you. And on behalf of the Dermatology Consortium of India, which has been very prime activity now by Professor Mathur and his dedicated team, we are proud to present you a certificate of appreciation as well as a memento, and I hope you would accept it. And
very nice, sir. Thank you very much.
Thank you so much for accepting it.
Dr. Lalit, can you please?
This is a surprise.
Chat questions, or shall I take?
Anyway, sir.
Please.
As you please.
Please, आप ले लो chat वाले ले लो.
So there have been several posts of appreciations, Dr. Mahajan, from Dr. Yasmin Jabin. Is she there?
Yes, sir. Yes, sir. I'm here.
So welcome, Dr. Yasmin. We have conveyed your message to Dr. Mahajan.
Yes, sir. It's actually a very difficult topic, and having such a nice presentation.
Our honorable members are always here. Dr. Niranjan Nagpur sir.
Dr. Nagpur is here, yes.
Dr. Janak Maniarji, Dr. Yasmin.
Brajesh, apparently Brajesh is also
I
here.
saw Dr. Bajaj sahab. I do not know, is it sir, Dr. Bajaj sahab hai ya nikal gaye?
Dr. Brajesh Nair is here or what?
Dr. Brajesh Nair, I have never seen some or other.
Brajesh, acha Brajesh likha hua hai. Maybe
no, he's not.
Maybe he is our resident, Brajesh Patel. So good presentation. Pictures were very good.
Dr. Dinesh, can I ask one question?
Sure, sir. Please.
Dr. Vikram Mahajan.
Yes, sir.
Your presentation is very good.
Thank you, sir.
How often such cases you see in a year in your area?
Okay. Sporotrichosis we see very often. Rather, we have published series more than 100 cases one time, and another 100 cases another time, and probably again the new series is coming up with more than 100 cases now. So we very often see sporotrichosis. Chromoblastomycosis, of course, we see pheohyphomycosis. We see these are all my personal collections actually. So we see all these kind of patients. But of course, other infections, these mycoses, they are uncommon. But this nocardia, mycetoma, eumycotic mycetomas, and chromoblastomycosis, and we see them quite often.
But these 100 cases you said, is it in how long? Because if you get about in 1 year, it is too. I mean, the incidence is very high in your area.
Yes, definitely. So we have this like I said, is a Himachal Pradesh endemic for sporotrichosis actually. So almost in last 5-7 years, we have seen more than 100-200 patients.
Have you ever encountered lobomycosis, Dr. Mahajan?
No, lobomycosis we don't see here because this is very limited endemic status of this.
Zygomycosis or phycomycosis? How about that?
No, zygomycosis we don't see very often.
Because at least in Bombay, where I am practicing,
Yes, sir.
even in the medical college where I was there, see, you don't come across that many cases. Maybe
Exactly.
4 or 5 cases in a year.
Mm-hmm.
It's
In
not.
Bombay, I mean, while reviewing literature,
But
we hardly find any
was,
reference from all these areas.
he must have collected since a very long period. Dr. Vikram, how long did you take to collect all these cases?
We almost continuously we are recording them.
Yes.
Sporotrichosis, we continuously we make them. I mean, we record them.
Dr. Vikram Mahajan is known for his serious efforts.
But
And
may I share one experience with everybody?
yes.
People have also asked about Dr. Mahajan about the
सर say it again sir, आपकी आवाज कट गई. हाँ नहीं आपकी आवाज कट गई सर दोबारा से.
Net is probably some difficulty. Net problem.
Dr.
Maybe.
Share one of my
Supersaturated solution of potassium iodide
Yes,
and its role in mycetoma. How do you prepare?
Mycetoma, no. Potassium iodide probably will not work alone. Mycetoma. Eumycotic probably, but in case of nocardial or actinomycotic mycetomas, drug of choice remains antibiotics.
But does it have an adjuvant role in making the drug reach out there in a better manner?
No,
because it
no,
would have
no.
a
How does it?
effect.
No. How does it work? Probably is more of a speculative thing.
Yeah.
Probably it prevents granuloma formation, or probably
Yes.
it opens up the granuloma.
It has got a fibrolytic effect also.
Yeah, fibrolytic. So it probably opens up the granuloma, or probably it prevents both, or prevents formation of granuloma. So that the fungus is exposed to the immunity or immunological aspect of the body, or probably the other combination of the drug, like itraconazole probably. So probably combination of SSKI with itraconazole probably will work better as compared to either drug alone.
Dr. Agarwal, you wanted to say something.
Yeah, sir, I wanted to share one of our series of the actinomycetoma cases, which we have published in the European Journal of Dermatology. And we have collected 18 patients. And as Dr. Mahajan had said, that the Wells regime works very well. But when we reviewed the Wells regime, we found that he has suggested injection amikacin twice a day for 15 days, followed by 21 days of the cotrimoxazole and rifamycin. But we had suggested one more modification, that we said that why to discontinue the cotrimoxazole and rifamycin during the hospital admission when patient gets amikacin. So we had given continuously cotrimoxazole twice a day, rifamycin once a day, and amikacin injection twice a day for 15 days, and followed by a rest period of 21 days, giving only cotrimoxazole and rifamycin.
Actually, this combination amikacin and cotrimoxazole probably is so-called Welsh regime. They have a number of modifications with this. So some people have added rifampicin to it, and they have obtained better results. So it's all permutation and combination, but I think two drugs they work sufficiently. So combination of amikacin and cotrimoxazole, usually people do tolerate them. And probably again, like I said, there is no guideline. There are no guidelines to when to stop the treatment. So probably it requires maybe for 2 years, maybe for 3 years. So depending on the clinical response, you have to keep on these patients under follow-up for the clinical cure as well as for mycological. Of course, mycological is difficult to identify, but probably again is more of an empirical. You continue for another 2-3 months.
Yes, sir. So that is what I wanted to share with you, that we had reported a series where we found that we can also put a guideline, which we have at the last in the last paragraph of the paper, this published paper. We have suggested that this is the 3 months you can give, 4 cycles you can give, 5 cycles you can, maximum you can give 6 cycles. So most of the patients with this suggestion that adding 3 antibiotics for continuous for 6 months, most of the patients they responded to us. Like you said that you have to go for 2 or 3 years. So that is what I wanted to share, that this regime works better than the interrupted cotrimoxazole and rifamycin.
Okay, what we follow is usually Welsh regime, and that is 3 cycles of amikacin, and of course cotrimoxazole is continued throughout the period, maybe 2 years or 3 years. So depending, and of course you have to keep on checking for the renal function, hepatic function, and hematological these parameters. So otherwise amikacin for 3 weeks probably is sufficient. 3 weeks, 2 weeks off, and then 3 weeks, and 2 weeks off, and 3 weeks. And in between, you just continue with cotrimoxazole in the same dose, double strength twice daily. And people do reasonably well with, especially with actinomycotic mycetomas. The patient I shown with the back and with the foot lesions, and they responded better, good, with this amikacin and cotrimoxazole.
It is referred most of the patient of the actinomycosis, though they respond. So what is your opinion of the mycetoma?
Mycetoma, they are difficult to treat. Frankly speaking, they are very chronic, indolent kind of the low grade simmering kind of infection. And in those cases, probably your itraconazole, of course, people have given, and the guidelines also say that itraconazole is a drug of choice. But people are using ketoconazole also, and they found a very good result with that. But again, problem with ketoconazole probably is more of a malign drug rather than I would say is a good drug which has been which has quite a bad name. And frankly speaking, only 1 or 2 cases we treated with the very initial phases when the ketoconazole was available. We treated ketoconazole. We use ketoconazole in mycetoma, and the people do respond to it also. But subsequently, probably it had a bad name, and so probably we stopped using it.
They have rather said it is not a good drug. The literature said, but I find that it's a good drug. Ketoconazole is a good drug.
Yes, that's what I said. Ketoconazole is a good drug, but the only thing is for prescribing, we are probably more scared for prescribing it.
Dr. Mahajan, what is the zygomycosis? Is it similar synonym with the phycomycosis?
In the past, it was known as a phycomycosis, but subsequently, this the genus probably they have changed the nomenclature for this, so it is no longer called as a phycomycosis. So it is a zygomycosis only now.
Well, anybody else who would like to contribute or question or comments?
They had few questions on the chat box.
That Dr. Lalit has taken. Lalit?
Yes,
sir, I have to. People who are interested how to prepare the solution.
Again, yes. What we do is we take little warm water, not very hot, not very cold. So warm water, and just keep on adding potassium iodide crystals in that till they get dissolved, and subsequently leave it for some time. And if there is a crystal formation, if you find some potassium iodide crystal at the bottom of it, then that means the solution is saturated. So as long as almost it takes quite a lot of this potassium iodide powder, and probably people try to give that much of add that much powder in that solution to make a solution. So you have to keep on adding till it gets fully dissolved, and some crystals are settle at the bottom of it.
I would suggest one simple formula also for this. 20 gram of the potassium iodide dissolved in 14 ml of the water makes it saturated solution.
Yes,
so that's what we are saying in our world. I tell my residents to take 20 gram of the potassium iodide, which is available in the market, and then dissolve it in 14 ml. That gives you.
You're right. You're right. But only thing, if you have some measuring scales and all those, probably the other method, we do is we don't require any scales. So simply you keep on adding the potassium iodide, the crystal in that water.
Okay.
How do you make out it is saturated or super saturated?
The super saturated, the potassium iodide will dissolve to a limit only. So after that, unless you keep on adding water, also probably that remain. So super saturated is nothing but saturated only.
Okay. Or is it that if you heat the solution, then you might insert some more potassium iodide?
Even if you do it after cooling of that water, the crystal will settle down.
Okay.
Surgical debulking. Someone asked about surgical debulking of something. There's some question on this.
Thank you.
All right. Thank you very much. Thanks a lot.
Bye.
Everyone.
Bye, Lalit.
Thanks, everybody.
Thank you. Thank you very much, sir. Thank you.
Thank you very much. Good night. See you next Friday.
Thank you very much, sir. Thank you. Thank you.
Good night, everyone.